sometimes it's difficult to go for an oral food challenge. So what we do basically is try to have a restriction diet for like some weeks, maybe 1 month or something, and try to understand if with this restriction diet, the kid doesn't have an urticaria exacerbation associated to this kind of foods and additives and conservatives and sugar.
So again, we have another episode of our podcast on Urticaria, and I'm excited. My name is Professor Torsten Zuberbier. I'm based in Berlin, Germany, an allergist, dermatologist, and president of GALEN, the Global Allergy and Asthma Excellence Network. With this subnetwork, you care for all our Urticaria centers of reference and excellence. And with me in this studio, I have Dr. Larissa Brandão from Brazil, on the other side of the world. Larissa, would you like to introduce yourself? You're a specialist in children urticaria.
Professor Zuberbier, thank you for this invitation. It is a pleasure for me to talk about chronic urticaria in children. So I'm a doctor, a pediatrician, and allergist and immunologist at Federal University of São Paulo in Brazil, where we have an outpatient clinic for chronic urticaria in children. So we usually see a lot of kids with this kind of condition, and it is very good for me to chat with you today and maybe change some ideas about chronic urticaria in this population.
Wonderful. So first of all, we all know chronic spontaneous urticaria. At least chronic spontaneous urticaria is certainly more frequent in adults, middle-aged adults, but there are special types also, like cholinergic urticaria, starting in younger age groups. So what is your feeling? What are the urticaria patients in childhood? Which age group? What do you aim at?
So at least here in São Paulo and in other centers of Brazil, what we see is that chronic urticaria usually starts in children about like 7 or 8 years old. Of course, chronic spontaneous urticaria is also the most common subtype of chronic urticaria in this population, at least here in Brazil. And when we talk about chronic induced urticaria, we still have the demographism as the most common subtype, but we also have some children with cold urticaria and with cholinergic urticaria. In our experience, sometimes it's hard to see a lot of kids with cold induced urticaria because here in Brazil, we don't have like a very cold weather. And sometimes these kids do not experience the linear, the cold they need to have urticaria. So we usually see these cases like children that went to a swimming pool or to the beach and the water was too cold, and when they travel, for example.
That's interesting what you're telling. My major question here is, in children with chronic spontaneous urticaria, you're in a setting where also maybe in tropical environments, maybe parasitic infections are more often. Do they play a role in children? We don't have much of that in Northern European countries.
Yes, what we see here is that we usually see that more in acute urticaria. So we have a lot of children that usually have skin manifestations when they get like viral infections or gastrointestinal infections. It's not in our experience to see a lot of kids with chronic spontaneous urticaria associated with infections. It's like sometimes they get worse of their urticaria, but they are not like usually related to it.
Okay, so it's pretty similar like in the guidelines. You do the same tests. The test is added differential blood count.
Exactly. Exactly. And of course, if they have other kind of symptoms that are not usually only the skin, if they have diarrhea or maybe cough or maybe another thing that make us think that they have an associated infection to the case, we usually, go for another types of exams and try to find some kind of infection that can be treated. And, we check if the urticaria get better or not.
Great. But you also just mentioned cough, which could also be asthma, for
Yes.
instance. That is a very relevant situation in adults. We know chronic spontaneous urticaria has a higher incidence of other allergic comorbidities. Is that the same in the children which you see?
Yeah, here we have like more than half of children have some kind of atopy associated to chronic spontaneous urticaria or chronic induced urticaria. And of course, in the first step is allergic rhinitis, but in the second one is asthma. So yes, we have a lot of children with asthma and they usually treat together with urticaria.
That's very, again, interesting because we always try to find synergistic treatments.
That
My question is, we have this treatment algorithm. The current treatment algorithm is antihistamines, updosing antihistamines, omalizumab, updosing omalizumab, cyclosporin A. That's a current one. We discuss the future in a moment. But what of these steps do you use in the children?
we usually follow the same algorithm that is recommended in the guidelines. And interestingly, what we see is that it seems that children have a better response to standard doses of second generation antihistamines when we compare to adults, for example. We only have like 7% of cases that needs to go further and use omalizumab, for example. So most of children that we treat have a good response to antihistamines in standard doses or even in higher doses. However, what we see in our practice is that the children that are using higher doses of antihistamines have more fatigue associated to the treatment. And sometimes we have to change the antihistamines or, take care of these children and put more attention to it.
I think that's very relevant. Inside the group of modern second generation medicines, there are differences. There are some which are less sedating, some which really do not pass the blood-brain barrier, which would be deslorotadine or bilastine, fexofenadine. I suppose you use all of these in the children?
Yes, we do. We have something that is difficult in our practice in the public health system, which is we only have one kind of second generation antihistamines available to use in children, like for free, which is loratadine. And sometimes we need to use it in higher doses. So we have to check regularly the function, the liver function. So in these kids, we don't have so many options. We depend on the family and we have to check if they can afford a better second generation antihistamines, if I can say so, like a better one, but with less collateral effects.
Interestingly, just for our people listening outside, loratadine is the pre-drug of desloratadine.
Yeah.
Desloratadine is the metabolite. Loratadine is pretty safe, also in higher doses. So liver problems are normally not recorded, but potentially, as it's still metabolized in the liver, that is the reason why Larissa just alluded to this liver checkup. But certainly the desloratadine, the metabolite, would be the better choice, but it's unfortunate it's not covered in the health system. One question. Actually, in the 90s, or was it 2000, I had once a study in children myself and looked at the effect of pseudoallergen-free diets in children. And interestingly, we found out that especially in children, there was a higher response rate than in adults to a diet, and that very often aromatic compounds and preservatives in sweets were part of the game, so at least aggravating. Do you see that in Brazil as well?
Well, Professor, this is a tough question because we see this very frequently and we have some kind of difficulty in understanding if this kind of situation really is like a potential exacerbator for chronic urticaria, or if, I don't know, it's a true food allergy, for example, because we know that this kind of situation doesn't necessarily involve IgE. So sometimes we have other kinds of mastocytes degranulation. And usually we should go for a oral food challenge and maybe try to understand it better. But these kids are usually going on use of antihistamines, and sometimes it's difficult to go for an oral food challenge. So what we do basically is try to have a restriction diet for like some weeks, maybe 1 month or something, and try to understand if with this restriction diet, the kid doesn't have an urticaria exacerbation associated to this kind of foods and additives and conservatives and sugar.
Okay, very interesting. Actually, just one word for those listening to us. We, of course, don't want restriction diets in children. We are always afraid that there is a kind of problem later. We want to avoid that. And for actually IgE-mediated food allergy, 48 hours already would be sufficient to stop symptoms. For the so-called pseudo-allergy, which is an X2 receptor related reaction, it takes 2 weeks, but it's not necessary more than 3 weeks. As restriction wouldn't help in the diagnosis, but it's very important again to say, like Larissa just said, we don't have an IgE test. We cannot do blood tests, we cannot do skin prick tests like for IgE mediated allergy. So we only have this tool of short-term restriction diet and having a good protocol what the children really eat in the end. Of course, if it's this one sweet, well, maybe they can find something else. And let's just jump once more to the inducible urticaria. Actually, cholinergic urticaria is more frequent, and I think it's rather young adults, 20 to 30 years. So that's not that many children, I suppose you see. But you mentioned cold urticaria. Well, Brazil isn't really cold, but it's the water. Is that the problem?
Yeah, what we see in our practice is that children with cold urticaria experience their symptoms when they go to, of course, for example, a cold swimming pool, or when they go to the beach, because sometimes there are some beaches in Brazil that have like cold water, and when they eat ice cream, for example, or when they drink cold drink with ice, for example, and they experience like lips angioedema. And this is what we see in our practice, because at least I'm talking here from São Paulo. We don't have like a very bad winter, for example, but sometimes our kids experience symptoms in the winter because their temperature to have symptoms is like, I don't know, maybe 18 degrees Celsius degrees. So, but in our practice, sometimes we see that like associated with eating ice cream or going to a swimming pool, or even when they travel with their families.
Yeah, and actually, it's by the way, it's not the outside temperature, it's the skin temperature, which
Exactly.
in water is easily at an equilibrium. In outside temperature, air temperature, it depends on the wind chill factor. And so often also in air conditioned rooms, when there's a airflow coming, symptoms can occur. Like you said, traveling in a car, if the air condition is too low, it can happen. More important, I think, is to mention there is, of course, a safety question. Cold water and also cold food can also, in rare instances, cause anaphylaxis, especially in cold water. I'm of course concerned, and sometimes we even offer adrenaline packs. Do you do that as well?
Exactly. We usually offer adrenaline to that children that already had an episode of anaphylaxis associated to cold urticaria. And this is quite common with like swimming pool, because their body surface area is almost entirely in contact with cold water.
Yeah.
So in this case, this is very important.
Yeah, and actually counseling. Children, they play, and then child A pushes child B forwards into the swimming pool. Hey, child B needs to know I get to climb out as quick as possible before anything happens,
Yeah.
because it's of course also the time. So counseling is extremely important. Counseling, I must say, also Brazil. You have many UCare centers. You're such an active nation in this area. New drugs are coming. As far as I know, we now have the situation that also the substance dupilumab, which is licensed also for asthma, is now also licensed for urticaria. Have you already had experience, or is it only licensed for adults in Brazil?
Well, here in Brazil, dupilumab for chronic urticaria is licensed for 12 years old and above for chronic urticaria. But I have some colleagues that had the experience to treat like asthma, use dupilumab for treating asthma in children that had also chronic urticaria. And they get better of both.
Good.
And we also have these experience with omalizumab, for example. There are some children that are using for asthma and they got better of chronic urticaria. And so this is like this kind of treatment, I think, is like something that we should use eventually when we have like these children with severe asthma and also with chronic urticaria, because we can like better than we can make them good in both ways.
Yeah, that's actually also in the novel guidelines, which have not been published yet, but I can give you a short preview. We will discuss that synergistic treatments for comorbidities may be a very important choice. So dupilumab, also with atopic dermatitis, licensed for both diseases, would be a good choice here. And so a lot of interesting things will come up in the very near future. Well, last but not least, at the end of this episode, Larissa, I've always admired your team in Brazil. And you day, 1st of October, it is some time, it's only spring now, but time rushes. You're again prepared to make advocacy for this disease on U Day. Your team is ready.
Well, yes, we are already preparing some things for U Day. And this year, we are thinking about reaching more patients through social media, for example. Here in Brazil, the population is very active in social media, and they usually follow a lot of websites and some profiles in Instagram and this kind of stuff. And they usually see a lot of videos. So this is a good tool for us to catch this kind of population. And also we already have some things or in some classes and some explanations for our patients in the outpatient clinic where they are like for real there with us. So we usually try to educate them for having a better understanding of the disease.
Wonderful. And actually, everybody listening now, we are about to say goodbye and have a good day wherever you are. Drive safely if you listen to us in the car. Stay calm if you are sitting on a sofa enjoying your evening. But remember, we need all of you for not only treating the patients, they need you, but also for advocacy. Unfortunately, it's still a trivialized disease, urticaria, the itch. Many people underestimate the real burden. Anyway, with that, I say thank you, Larissa. Please say bye-bye to all our listeners.
Thank you for this invitation, Dr. Zuberbier, and thank you for all of you that are listening to us today. It is a very pleasure for me to speak about chronic urticaria in children. Bye-bye.
And thank you, Larissa, once more. And remember, everybody listening, this is not the last you will hear about us. This podcast series will go on, so stay tuned. Thank you. Bye-bye.